We'll move on now to our second speaker, who is Sara Thorne. She is Associate Professor at the University of Toronto and a consultant cardiologist at Toronto General and Mount Sinai Hospital. We all had the pleasure of also working with her for a long time in the UK when she was working in Birmingham. And she's going to speak to us today about managing pregnant women with congenital heart disease.
Thank you very much, Kath, and good morning, good afternoon, good evening to everybody. It's a real delight to share this webinar with you. And then I'm going to go straight for the most complex sort of congenital heart disease and talk about the Fontan's circulation and use it as an example of how to approach one of the most complex conditions. You've seen this slide from Kathy Nelson-Piercy already. Heart disease in the UK is the biggest cause of maternal death, and it has been the case for many, many years now. This is a slide of Kathy Nelson-Piercy's that's an old slide, but it holds true. This looks at cardiac causes of maternal death over several decades, and if you look at the yellow line bumping along the bottom, those are deaths from congenital heart disease. And there's been no change in deaths from congenital heart disease over the decades, despite increasing numbers and increasing complexity of disease in the women who are getting pregnant. And if you were to follow this line out to 2020, it would be the same. It has not increased. These are the most up-to-date maternal cardiac causes of death in the UK. And of the 84 women that died over this 3-year period from heart disease, only 4 had congenital heart disease. So the numbers are low. Why is that? If you think about all women who die with heart disease, most of them, that's 3/4, were not known to have heart disease before they got pregnant. And that means they are dependent on rapid diagnosis by non-specialists when their heart disease makes them decompensate. By comparison, women with congenital heart disease are nearly always known to have heart disease, and therefore they should have access to specialist pre-pregnancy counselling and specialist pregnancy care. I can't prove this, but I choose to believe that that's one of the main reasons why we don't see so many women with heart disease dying. It's because they have access to good care. Now then, let's think about pregnancy with a Fontan's circulation, and the key here is to understand the anatomy and the physiology, to consider whether that's a circulation that can adapt to pregnancy, to consider the impact of pregnancy on the heart condition and the heart condition on the pregnancy. So we should look at the published data. It's not great, it never is in congenital heart disease. There's retrospective case series and we know about outcomes. And then we put that together to consider how we should advise and care for these women. I'm going to make the Fontan's circulation easy. This is a heart with a functionally single ventricle. And the decision with the Fontan's circulation is to say you will use this ventricle to support the systemic circulation. So the red blood is pumped into the aorta and around the body, and the blue blood goes through some sort of connection straight into the pulmonary artery. So there is separation of red and blue blood, which is a good thing, but there is no subpulmonary ventricle. And that means that there is passive, non-pulsatile flow into the pulmonary arteries with a relative fixed resistance. And there is a limited ability to raise cardiac output in response to pregnancy, and really importantly, an inability to tolerate volume loss. So this is a woman with a low cardiac output state. Her ventricle is preload deprived, and her output is dependent on high systemic venous pressures. As a result, there are multi-system sequelae with end organ damage, particularly to the liver, and there's clotting, both clotting and bleeding tendencies. And in most women and men, the circulation starts subtly to fail by the time they reach their 30s, with arrhythmias and then this terrible situation that we call fontan failure, when the whole circulation becomes less efficient. So let's stay with basic physiology. I'm sure you all know this slide well. Here is the rise we expect to see in cardiac output during pregnancy, achieved largely through an increase in stroke volume. Can the fontan circulation do this? Now, clearly, we're going to be worried that it's not going to be able to achieve that as efficiently as someone with a two-ventricle circulation. So what about outcomes in pregnancy in women with a fontan circulation? What happens? For the next couple of slides, I'm going to refer to two publications. The first is a systematic review looking at the world literature and pulling out the studies that have been performed to a good enough standard to include. The second is a multi-centre UK study, and between them, they look at something over 300 pregnancies and around nearly 200 live births. Take-home messages from these studies are that miscarriage is really common. About 50% of pregnancies will end in a miscarriage, mostly in the first trimester. Premature delivery is also very common, somewhere around 60 or 70%. And those deliveries are early for a number of reasons. Sometimes it's intervention because of maternal decompensation, because she develops heart failure. Sometimes it's for fetal well-being. But also for obstetric reasons, so premature rupture of membranes and placental abruption. In these women with a low cardiac output state, small for gestational age is also common, somewhere between 20 and 50%, and neonatal death is also increased around about 5 or 6%. What about maternal outcomes? Amazingly, there are no maternal deaths reported in the world literature. And that is something that we would perhaps be surprised at, given that this is such a fragile circulation. But despite there being no maternal deaths reported, there is significant maternal morbidity. So the same two studies, looking at around about 150 women, find that arrhythmia occurs in around 10% of women, heart failure in somewhere between 4 and 10%, and that's usually in the third trimester and in the early postpartum period. Postpartum hemorrhage is also common and is weakly associated with anticoagulation. So can we further stratify pregnancy risk for women with a fontan circulation? If we look at the European Society of Cardiology guidelines from 2018, they classify the perfect fontan, that's the woman who's had no complications, as modified WHO3, so a significantly increased risk of maternal mortality or severe morbidity. And a woman who's had any complication at all is extremely high risk, and pregnancy is contraindicated. This is reiterated in the 2020 ESC guidelines for the management of women with congenital heart disease. So this is telling us that we should counsel against pregnancy any woman with a fontan circulation who's had any pregnancy. Really? This is a condition with no reported maternal deaths. All the other group 4 women who we would classify here have heart conditions that put them at increased risk of death. We don't know that that's the case for women with a fontan circulation, but the published data would suggest not. They are, however, women who have an extremely high risk of morbidity and poor pregnancy outcome. So perhaps we should consider the physiological stage of the woman with a fontan circulation as well as the anatomical diagnosis. And this is, I don't expect you to try and read all this. This is from the American Heart Association and American College of Cardiology guideline for the management of adults with congenital heart disease. So it's not just about pregnancy. And this asks us to just think, for any patient that we're looking after, what is their functional and physiological state, as well as what is their diagnosis. And I think this is an important approach. In my last post in the UK, in Birmingham, we used this sort of idea to consider if we could further stratify pregnancy risk for women with a Fontan circulation. And we grouped them into women of a lower risk, they're still high risk, intermediate risk, and very high risk, according to their functional status, their oxygen saturation, their ability to exercise, their ventricular function, whether they had any regurgitant valves, whether they had Fontan-related complications, or whether they had what we call a failing Fontan circulation. And we found that the number of pregnancies and live births reduced as the women became higher risk. Our numbers were too small to determine whether maternal morbidity was increased. Now, clearly, it may well be that the women at very high risk chose not to have a pregnancy, and there's some evidence to support that, but nonetheless there were some women, a small number of women, who had a high number of pregnancies in these high risk groups with poor fetal outcome, so they didn't have a live birth. Let's think now, before we end, about obstetric factors. Bleeding is a real problem for the woman with a Fontan circulation. We know that postpartum hemorrhage rates are high, and really importantly, remember, this circulation does not tolerate volume loss. It is really critically dependent on a high systemic venous pressure to allow to push the blood through the pulmonary circulation. So hemorrhage is poorly tolerated. Because it's a procoagulant circulation, many women are anticoagulated. Most women are anticoagulated throughout their pregnancy. Their circulation puts them at an increased intrinsic risk of bleeding, and then they may be at iatrogenic risk of bleeding because of the way we manage the third stage of pregnancy, the third stage of labour. We are fearful of giving the routine doses of syntocinon and uterotonics to women with heart disease, and particularly women with complex circulation such as the Fontan circulation. And this means that these women are often given a lower dose of syntocinon over a long period of time, and this may also add to their increased risk of bleeding. And then just lastly, ending with a question to ourselves, what is the role of placental insufficiency in the Fontan circulation? We know that this increased systemic venous pressure, the chronic low cardiac output state, and often chronic hypoxemia causes end organ damage. And we know quite a lot about that in organs such as the liver, but we don't know very much about it in the placenta. This is a small study from the Mayo Clinic looking at the histology of the placenta in women with the Fontan circulation, and they found subchorionic fibrin deposition and villus hypoplasia, suggesting poor placental physiology. And this might have a role in the small for gestational age and preterm delivery that we see so often in this circulation. So my last two slides are to summarize questions rather than answers for women with the Fontan circulation. Should we be advising women without a perfect, we don't know yet the long-term impact of uncertainty and unease about it. We know that there's a real problem with bleeding for these women, and some of these women are at lower risk. Maybe we should be reducing their level of anticoagulation during pregnancy, which is not something we would usually consider. There may be a role of placental insufficiency. And then lastly, there is subfertility in women with a Fontan circulation. We know that in IVF, in vitro fertilization, carries a high risk, particularly of ovarian hyperstimulation and thrombosis. And we also know it's rarely successful. And then to end, just in general, back to congenital heart disease in general, the adult congenital heart population is increasing in size and complexity, but it continues to be a small contributor to maternal mortality figures. And that, I think, is because we have the opportunity to offer expert care, before, during and after pregnancy. So women with complex conditions can have successful pregnancies, but at a cost of significant maternal morbidity and fetal mortality and morbidity, and with the need for specialist multidisciplinary care. Thank you very much.
Thank you very much for a very, very interesting lecture, which has already brought in a number of questions. If we stick first to your comments about Fontan and delivery, there's a question about whether you think it's advisable to shorten the second stage.
I think it depends on the woman. So if we've had a woman who has done very well in her pregnancy and has gone through and has gone into labour at term, I wouldn't necessarily shorten the second stage, but I would have a low threshold for shortening the second stage if I felt she had any complications or she was not doing well in her labour. So I think she's somebody who needs senior experienced clinicians present during the labour to make the decisions. This is not somebody that you can manage with an algorithm.
There are also questions about the role for carbetocin for postpartum hemorrhage in these cases, and also whether tranexamic acid can be used.
So yes to everything. I think the risk for the woman with a Fontan circulation is the risk of bleeding is much, much higher than the risk of being concerned about the drugs that we're using. So I think with good monitoring, you have to use whatever is in your armamentarium if you have a woman with a PPH. Trying to take her for an emergency hysterectomy is going to be really very high risk. So I think use all the drugs you've got if PPH occurs.
Thank you. There are some general questions as well. One from somebody who's unfortunately had somebody who had a cardiac arrest with significant congenital heart disease, but asking about your thoughts about timing of delivery.
For in general? So I think
in general, yes.
So in general, I would do the same as I would with any other woman who has a complex medical condition. I would individualise the decision, and if I have somebody who's doing well, her chances of having a straightforward delivery is going to be better if she has a spontaneous, if she goes into labour spontaneously. For many women with complex cardiac conditions and a fragile circulation, removing the element of pain is really important. So probably the least cardiovascularly stressful way of giving birth is to have a spontaneous delivery, an early epidural, allow the baby to descend passively and lift the baby out. That's, for most women, that's probably the least cardiovascular stress. And if you've got somebody who you think is really fragile, that may be a better option than a planned caesarean section. But you have to see how the pregnancy is going, and many women with complex disease have other reasons why they may need to go for a caesarean section, in which case you have the opportunity to get the A team on board and to plan everything very carefully.
Thank you. We have an interesting question about a specific case. A woman who has presented, she has a previous history of cardiac septal myomectomy, or HOCM, who is now pregnant with no pre-pregnancy counselling. And the question really is about management and would you recommend starting heparin?
So this is a lady with hypertrophic cardiomyopathy and a previous myomectomy. It depends on her situation. Many women with hypertrophic cardiomyopathy tolerate pregnancy very well. I would probably only anticoagulate her with low molecular weight heparin if she was having atrial arrhythmias. I think the time of most risk in general for women with hypertrophic cardiomyopathy is around the time of delivery, because these women have a stiff ventricle and they don't tolerate volume shifts. The key here is to keep the woman euvolemic. She won't tolerate blood loss, but similarly, she won't tolerate the increased blood volume just after delivery and at the time of delivering the placenta.
Just in the last few minutes, we've had a number of general questions, some relating to when patients with cardiac disease require to be taken to the cath lab for cardiac catheterization, and your views on safety?
So I can't remember the last time I took a pregnant woman with congenital heart disease to the catheter lab.
I would think of this maybe as a question relating more to other cardiac disease.
Okay,
as well.
so the time that you're most likely to do that is if you have a woman who presents with an ST segment elevation myocardial infarction. You may choose to do a CT coronary angiogram first if you think this is a coronary artery dissection, but otherwise I would have no qualms about going to the catheter lab. Usually we go from the radial artery now, so there's very little radiation to the fetus, and the radiation dose is small. The other time we would take somebody to the catheter lab is a woman with severe mitral stenosis, and again the radiation dose is really low. So I would have, if you have a real need to get to the lab, I would go. I would not close somebody's atrial septal defect during pregnancy, because I cannot think of a reason why you would have to do that as an emergency. I would manage such a woman conservatively and close the atrial septal defect after she'd given birth.
Wonderful. Sadly, once again, we have many questions, but we will have to stop now. Thank you for a wonderful talk.